Rosie ma'am, shall we start?
Yes, sir.
People will join slowly. It is already 30 people. We can start.
Okay, sir. Welcome back for the second scientific sessions. Now it's time for the second oral presentation. I call upon Mr. Subhajit Ghosh, Associate Professor, Vilas College of Pharmacy, Mysuru, India, for oral presentation. His topic is a comparative evaluation and potency enhancing standardization process, one of the Ayurvedic oral formulation as an antioxidant and anti-aging substance. Over to you, sir.
Good afternoon, everyone. Myself, Shubhajit Ghosh, Associate Professor, Sarada Vilas College of Pharmacy. I'm starting, my topic is a comparative evaluation and potency enhancing standardization process, one of Ayurvedic oral formulation as an antioxidant and anti-aging substance. But before the starting, I am explaining why the title is like this. Because of this comparative evaluation means we are comparing same formulation by different source. We are preparing by two way. Another is marketed formulation. We are comparing here, and here is meaning of potency enhancing standardization process means whole the process from the first to last required to standardize all the individual process. It is very important to quality control as well as the maintain the therapeutic activity. Everything is depends on this particular standardization process. Nowadays this is very essential because all over the globe or all over the world people are concentrating then one alternative medication less adverse effect related, very cheap they want to this. That's why people are concentrating on herbal or ayurvedic, this other way of medication process than synthetic. So in this way we are concentrating the antioxidant as well as anti-aging substances. Now, with the respect to my guide, Dr. P.N. Murthy and Dr. Hanumanchar Joshi, the principal, Sarada Vilas College, I am starting this process. With the respect to the god of Ayurveda, I am starting my next way. That is the abstract processes. I told here the one of Ayurvedic oral formulation. That is the name of this formulation is Ashwagandha Arista. Ashwagandha itself is a very good anti-aging substance as per the Ayurveda, and Aristo is the liquid dosage form formulation. Why we are using this Arista formulation? So many formulation are here, like solid dosage form, semi-solid dosage form, liquid dosage form. But what happened? This liquid dosage form, Arista itself is a hydroalcoholic formulation, and then this Aristo having a huge use in Ayurvedic traditional medication system. And another thing is oral liquid dosage form is easily can absorb through the system, and they can show the activity than compared to other solid dosage form. That is a good showing the activity as faster than solid and other type of dosage form. So many Aristo formulation is there, liquid dosage form, Sura, then other type of formulation is in our Ayurveda. But we are concentrating one formulation, Ashwagandha Aristo. The main story behind why they are showing this antioxidant activity as well as anti-aging. What is the reason behind? What is the chemical composition behind it? So when we are identified the formulation Ashwagandha Aristo, then we identify some phenolic and flavonoids are there. Flavonoids are there. These polyphenolic compounds and flavonoids are showing mainly these kinds of antioxidant, anti-aging activity, hyperlipidemic activity, so many related to the cardiac disorder. Sometimes it's a blood purifier, hepatotoxicity can be reduced through this process. In this polyphenolic compounds, we can identify gallic acid is there, catechin is there, So many compounds are there, other compounds also be there, but these compounds are major present in this formulation. And flavonoids are routine also be present as a huge means percentage. So what we are doing, we are starting from this material, means before the preparation of ashwagandha arishta, we standardize the whole the ingredient. In ashwagandha arishta, so many means herbal ingredients are there, but one of the major percentage is ashwagandha arishta, ashwagandha, and then we are other ingredients also added as per the Ayurvedic pharmacopoeia, and then we are standardized the process through this way. Now everybody knows the whole the people 21st century, they are concentrating on biotechnology, herbal technology, information technology, means bioinformatics sciences. So herbal, we are concentrating on the herbal formulation, herbal drug therapy all over the globe. We are concentrating nowadays. So the present condition is the growing of these herbal industries. So many investment is going on, national and international. The synthetic drugs having so many adverse effect. So prevention of these, prevention and quality, for the purpose of quality control, we are starting this concept. If we are given the standardized product, then it will be good for health as well as cheapest and also more effective. Now is globally the market of herbal drug is every year is increasing 6% annual growth as per the our last 10-year study. USA also investing, United Kingdom also, Malaysia, Korea and all. And one very interesting thing, India is one of the major sources of some herbal drugs. Their raw material as well as Ayurvedic formulation also exporting, and that is a very good sign for the all over the globe. They are all means concentrating and a different way of medication, and it is a more effective. Now the the effect of serious side effects are showing for some synthetic drug. That's why people are not believe on this, or otherwise avoiding the means synthetic compounds or formulation. They concentrating on Ayurvedic formulation or herbal formulation, and in-house formulation also. Some people are concentrating around means for the beliefness there. Now I am coming the what is the best suitable formulation for other disease. First of this, AIDS also be Ayurvedic formulation is good, means product are available. Some diabetic, in case of liver disease, in case of anti-cancer drug, some other thing. But one of them is anti-aging substance also be good using for Ayurvedic formulation. And another very interesting thing, Alzheimer, Parkinson, all are neurological disorders also be can reduce or remove or can stabilize by this Ayurvedic formulation. Now, as per this Ayurveda, so many pharmacopoeia is there all over the world for related to the standardized the herbal medication. Chinese pharmacopoeia, European pharmacopoeia also be included here. But Indian pharmacopoeia, Indian herbal pharmacopoeia, Ayurvedic pharmacopoeia is there. As per this, we are following or preparing the whole the process. Now the globally we can identify so many who are included, so many plants are having the activity. They can 91 countries as per the last scenario using these kinds of formulation. In African countries also concentrating on this. In India, near about 20,000 species are identified for the Ayurvedic means herbal activities there, and we are going to standardize one by one, and day by day we are developing on this Ayurvedic concept. Another very interesting thing we identify, the India is a mega source, major herbal ingredient is a source of herbal drug. Ayurveda, and also Ayurveda is invented from this India. and with a huge years of the history, past history, we are using this one by, and also nowadays we are scientifically improve these things. Now, as per the strength of Indian herbal technology, 10,000 species are identified, 8,000 medicinally approved. They are having some activity. Though, as per the research process is going on. Now, in the strain, in these 8,000 species, 900 species are established as an Ayurvedic drug, herbal ingredient. Unani also 700 species. Some species are Unani and Ayurveda also similar. That is, there also 600 species are identified. Others also be modern herbal technology also identified some species. But we are using on this Ayurvedic is 900 species of sample we can use and mention in Ayurvedic pharmacopoeia about them, what is the microscopic character, what is the standard cultivation collection process of this particular, what is the origin, what is the source, and what is the irrigation method for this particular, how to develop this constituent, and which time is suitable for collecting the herbs, which portion is active for which activity, means sometimes some drugs leaf is active, some is bark is active. That is identified by Ayurveda. Now, according to the World Health Organization, the 70 to 95% of global population are now believe now they are started to believe on herbal medication or alternative medication, we can say. Because of that, so many things are there. They are identifying these the natural therapies. Some people are believe on natural therapies, natural because of that less side effect. Some conventional therapy is more effective than other way. Self medication is possible. The synthetic product has high cost. Okay, that is the reason behind it. How we moving to or changing the flavor of medication system. Now the thing is, we are as per this Ayurveda, some pharmacologically active ingredient are identified. We have so many Vedas, Charak Samhita, and other means systems. They are means given the identity of particular drugs and particular formulation, how they are acting, how they are using, what is the use, how we are administering these things are there. Now, the meaning of Ayurveda is Ayur means life and Veda means science or knowledge. As per them, we are classified the oral Ayurvedic dosage form. That is the three, every dosage form having the three way: liquid dosage form, semi-solid dosage form, and solid dosage form. In this liquid dosage form, Katho, Kashaya is one of the preparation, Arka and other type of preparation is there, Sarada, so many preparation are there. But we are identify this. Arishta also be one preparation. Arishta is a we means identify this one because of that hydroalcoholic formulation. Here is alcohol is there. That's why the stability of drug means we can preserve this one is for long time, because everybody knows this alcohol itself is an auto preservative activity is showing. And another thing is this is liquid dosage form. That's why we can use very easiest way. Self medication after self administration is possible through this, and it is very effective as well as very easily can absorb to the system. Now, semi-solid is also a kalka, lepa, so many types of semi-solid dosage form is there, churna and other type of vati solid dosage form is there. But we are concentrating here in this part, we are concentrating on the liquid dosage form, ashwagandha arishta. As per the current scenario of the research, so many people are concentrating on churna, the different type of churna is available in market. But one very interesting thing, they are all are means going through the process by pharmacological activity. Some pharmacological scientific evidence is there, but in the analytical profiling means scientific evidence analytical profiling means we want the what is the reason and what is the constituent is responsible for particular activity. and how much amount this constituent is present in this formulation, that is also required, very essential for a scientific evidence of a particular compound. That some very rarely ashwagandha churna is identified by TLC profiling. You can see the analytical profiling TLC is done for them, but other modern technology is HPLC, LCMS is required to perform for this. So then we can identify this is a good, what is the reason behind it, how much constituent is there. We can mean scientifically prove this is a good product for this particular means constituent. If any impurities or other ingredient is mixed with this, then we can also identify for them. So as per this, Arishta's formulation is the Arjun Arishta is there, Ashoka Arishta is there, but only a few things are identified in the analytical profiling, what I mentioned in the previous one. Also, Ashoka Arishta, some work is done by TLC only. That solid dosage form also here, HPTLC, and they are identifying. The Rashayana, so semi-solid dosage form, but very rare cases they are done by HPLC method. That's why we are concentrating on this analytical chemistry of this particular formulation. Google also one of them. Now I am coming the my aim of this research. Why I am concentrating on this? The present research is aimed to prepare ashwagandha arista by traditional and modern method. Traditional method means what in mention is traditional pharmacopoeia, means Indian Ayurvedic pharmacopoeia. What they mention, we are following as it is way. But in modern method, but we are little bit of modified. Why modified behind is, if we are following the traditional method of preparation, it will be take 15 days for formulation of 3 liter of ashwagandha. But if we are modernize this process by a little bit of changing, then it will be within 5 to 3 days, means one third reducing the time. We can develop the same product as well as same concentration of ingredients we can prepare by modern technology. And to standardize them with respect to physicochemical evaluation and analytical profiling involving the comparing to each other marketed formulation, and we are comparing these two formulation, traditional method and modern method, with comparing with the marketed formulation, because what is in market, what is the constituent is there, exact constituent is present is or not, we are identifying for this. Cardioprotective activity, which is a means agent related problem, major cases are there. Polyphenolic compounds we are identified, flavonoid rich ingredient we are identified, and strong antioxidant potential we are also determined due to this process, due to our work, that we are identified this is a good for anti-aging and also anti-oxidant substance. Now, most of the challenges is here because of that lack of scientific evidence of this particular Ayurvedic medication system. Scientific lack of scientific evidence. We want to develop. We want to give a quality product with scientific evidence. Okay. So due to this, we are identifying the thin layer chromatographic process, high performance thin layer HPTLC method. HPLC means high performance liquid chromatography. But in case of some cases are gas chromatography, liquid chromatography with MS means mass spectroscopy, we are identify the molecule of this. That is the way how we are standardizing. I'm coming one by one the process. In the ICMR, also we standardize some drugs through this process. Triphala is one of the good good scientific evidence product for Ayurveda, that is huge users, and also it is a huge means market in India and also outer countries also in globally. We are using this Triphala. Everybody knows nowadays. by these formulations are approved by ICMRI, and Government of India is approved for this product. Now our methodology is first identify the which oral Ayurvedic formulation is good, effective for particular activity by the traditional books or traditional literature survey. Then we are collecting the ingredient. It is a very important step through authentic identify the herbal ingredient, authentified this one. Without authentication, we cannot say it is an adulterated product or different species or what type of product. That is very important thing. Another thing is the collecting time. Each herbal ingredient having a particular time, we should follow this, how to collect, what is the way of drying, what is the way of grinding, everything we should follow, because everything having one meaning. uh, and also how we administer, which vehicle is required for administration. Sometimes is water, sometimes we change with season, we are using different way of administration. Means sometimes is required to administer through means honey, sometimes is required to curd, sometimes is required to salted water, sometimes it's like a saline water or salted water. That is different way of administration is have. And Ayurveda is mentioned in this. Because of that, ingredient are active on this condition. And we are preparing the Ayurvedic formulations as per our recent work is Ashwagandha Aristo we are preparing, and the one is modern technology, one is traditional technology. And then after the preparation, we have standardized the formulation. It may be pharmacognostic parameter, what is the solubility, what is the extractive value, everything is there, and then chromatographic properties, then marker based analysis, what constituent is there, and then how we are identifying what is the exact means how much concentration is present in this means liquid. And then toxicological contamination, microbial, pesticide, heavy metals, this is required, definitely required for identifying microbial contamination, pesticide and heavy metal from starting material also. Because these heavy metals sometimes is inside of this formulation, they are given some problems, just like mercury or arsenic. Nowadays is a huge source from water, that is very difficult, and they are hampering the means skin, their effect on skin or age related problems will arise from these heavy metals. And some people are for more means irrigation, they are using the pesticides, huge amount of pesticides also using nowadays. That's why required to identify the pesticide compound. And safety, efficacy also and self estimation, self life estimation. We studied about this by thermogravimetric analysis, how we are stabilize this drug, how long we can stabilize, what is the effect of temperature up to the 1200 degrees centigrade, why what is the condition is arise in between this form. And then we are studying the comparative way. That is our standardization process. For standardize the materials, standardize the material in means herbal ingredient are collecting in a particular time, and then drying. Drying is a particular process, because if volatile substance we are identifying, then required to below 50 degrees centigrade should dry. Otherwise, what happens? The volatile substance will be evaporated. That's why be carefully as per our constituent. We are drying the whole the process. Then we are preparing the ashwagandha arista by traditional method, and then we prepared the formulation by modern method. I will tell you in the next slide what is the difference between traditional preparation and modern preparation, what is the changes we make here. And then we are coming the physico chemical evaluation of the formulation, that is required to how to physico chemical, what is the constituent is there, identify it may be alkaloid or phenolic compound, or what type of these flavonoids are there, we are identify this one. Then we are studying in two way. One is phytochemical evaluation and pharmacological evaluation for the establish the scientific evidence. Pharmacological evaluation we done in vitro antioxidant. superoxide radical scavenging activity, lipid peroxidation assay, cardioprotective activity, and then anti-hyperlipidemic activity, anti-diabetic activity, diuretic activity, all these. After that, evidentially prove this a particular drug is responsible for this activity. Then we go to the identify which compound is means essential or which compound is responsible for that particular activity. That's why preliminary phytochemical screening we done. And then the main things are comes one by one. That is estimation of total phenol content. The solution is how much phenolic compounds is there. That therefore they are showing the antioxidant activity, and then estimate the total flavonoid also. Then TLC fingerprint. After this TLC fingerprint, we identify the solvent system, and then we go to the HPTLC method development, and what constituent is how much amount. This through the graphical representation we can compare through three formulation. Method development by quantification of marker compound by HPTLC high performance thin layer chromatography, gallic acid and ellagic acid and routine and this catechin all are identified through this process. Now, the part one is the phytochemical and analytical studies. After the formulation authentication, we are preparing the raw material are collected and raw material total ash, acid insoluble acids, water soluble extractive value, alcohol soluble extractive value. All these things we are done. And in case of raw material, pesticide, how much is the pesticide and what pesticide is present and what is the level it will be in means harmful or non-toxic that we are identified. And then thermogravimetric analysis we done, and then we come the formulation, the prepared the formulation. But here is one very required thing is why we are telling this ashwagandha is anti-aging substance. This is related with anti-aging and antioxidant substance. But anti-aging herbs in 8 herbs is present in Ayurveda. Most usable 8 herbs is present in Ayurveda. Then in between these 8 are one is Guduchi, Gugulu, Brahmi, Amlaki, turmeric, ginseng, Gotukola, and ashwagandha is one of the best. Those are rapid cell regeneration is helps for this ashwagandha. That's why we taken this one is ashwagandha aristo formulation. Now 3 formulation we are under study. One is test formulation is ashwagandha aristo. One is market. This one is a marketed formulation. One is ashwagandha aristo tea, means this one is the traditional method. We follow the traditional method for the development of this ashwagandha aristo. And ashwagandha aristo M means this one is the modern technology we following for the preparation. Now this is the ingredient we use for the ashwagandha aristo preparation traditional method. Here is the we can see the ashwagandha is the 600 gram major constituent. That's why we can the name is comes under ashwagandha aristo. 600 grams for 3 liter of ashwagandha aristo is required to the 600 gram. And here just come with the 22nd number. 22nd number is wood florida florobinda Dakati flower. Dakati flower we are using for the natural fermenter. This one is the natural fermenter, and as per the Ayurvedic, we are using this one. That is near about 200 gram we use for 3 liter of ashwagandha aristo. And here is the our trick. We change in case of just traditional method. We are using this Dakati flower, wood florida florobenda. But in case of our new modern technology, we just replace this flower or wood florida florobenda by yeast. Yeast is increase the fermentation process. But I am again repeating, this yeast process is not accepted till now by our Ayurveda. What is the reason behind it? Because of that, it generate the alcoholic concentration is huge percentage they are generating, and easiest way they are fermenting the process is very fast. That's why not approved till now But why we are mentioning, we are reducing the time span for the preparation of this liquid or formulation. Because if we are following the traditional form, then it will be take 15 to 13 days minimum for the formulation of 3 liter. But if we are using, in case of Dakati flower is yeast, then it will becomes under 3 to 4 days whole the formulation is done. Okay, that's why we are changing this one modern technology, and we are comparing with this, and one marketed formulation we are under in study. And after the formulation, we evaluate the determination of the pH, specific gravity, and total solid content, sugar content, alcohol, and again required to identify if any heavy metal is there, phytochemical screening also, and then major part is phenol and flavonoids, how much amount is that there, and HPTLC method for the quantification through marker compound. Now we came the pharmacological scavenging activity. All these things are antioxidant related. Then we are going to this. Now ashwagandha aristo, we are making the diabetic rat and this study. We get the identified this one flavonoid and phenolic compounds are there as per the result. Now we studied the phenolic concentration by the means graphical representation, the huge amount of phenol and flavonoids are there. Then we identified the how much amount of exact phenol is weight by weight is here. Means flavonoids are here. 0.16 grams are here also. Ashwagandha near about all are ingredient and same. But one marketed formulation, I am not telling the brand name. They are having the concentration is very less. They are only branding, but the constituent is not good. But here is one branded product we are taken, that is good constituent is there. Here identify the gallic acid, all these responsible compounds by HPTLC method. HPTLC method development by standard drug, standard potential, how much we identified. This is the amount we get from this particular means formulations, that is near about all are equal. This is our plates. Where is the gallic acid we are identify, ellagic acid we are identify with the standard and compared to the other means other solvent. This marketed formulation and other comparison method we identified through this process. Here is the clearly evidential proof of itachin is that much amount in our solution with the standard drug. We can see this one is the ashwagandha aristo W1 and W2 is the marketed formulation, and W3 also, just you can check it, this compound is there present. Then also fingerprinting for the study of this other compound routine also be identified here by this method. And this is that chromatogram by we are identified the gallic acid, what constituent, what is the concentration is exact is there. These things are there for ashwagandha aristo, for ellagic acid. This is for catechin. This is for routine also. This concentration is moral of this equal. Now we are standardized this HPLC method for this particular calibration curve method for the standard gallic acid. We are identify this all these 5 ingredients. Then our conclusion of this, we can say that after the studying of all this process, this ashwagandha aristo is having this type of in vitro antioxidant activity. Those can use for the particular these constituents are there: gallic acid, ellagic acid, catechin, flavonoids. These all these things are there, and they are responsible for antioxidant as well as this one is the anti-aging substance, age-related means things can be means possible to reduce through this. But as per the medication, as per the under the supervision of doctors, only required to take what dose is suitable for you, This is required to identify and which condition we are applying, what is the way of administration. Everybody after the justification only you can take this one. Otherwise, every drug, it may be herbal or it may be synthetic. If self-medication is not good for the all, with the supervision of doctors is required, only take the drug as if you are taking as a drug. Okay, that is our the topic we explain here related to these things. Ashwagandha Arista. This is the references. We followed this one WHO guideline, then other also so many. Pulak Mukherjee sir also be ethnopharmacology some documented for these drugs. Some Raul Fia also be identified. Some Indian Council of Medical Research is given some data for this purpose. Our publication, we are working on this antioxidant activity from chewing formulation, some other standardization, other polyherbal formulation also. If any question can take.
No, we are ready with next one.
Thank you, sir. Thank you for your valuable information.
Okay, thank you
So
all of
we
you.
can move on to our next oral presenter. Our next oral presenter is Mr. Sachidananda R. Adiga, PharmD intern, Krishna Rajendra Hospital and Sarada Vilas College of Pharmacy, Mysuru. His topic is need of palliative care and affective disorder challenges in pain management for improving quality of life among elderly cancer patients. Over to you, Mr. Sachidananda.
Am I audible?
Yes.
Okay. Good afternoon, everyone. Like my name is Sachidananda, as Dr. Rosie ma'am explained about give the introduction about me. Like first of all, I need to thanks my heartfelt thanks for the organizing committee as well as the scientific committee in order to select my work as to present in this oral presentation. Without wasting a topic, let me go to my work. Okay. Now I explain about what is need of palliative care, and my topic is affective disorders challenges in pain management for improving quality of life among elderly cancer patients. Why I chose this topic means this topic comes under the theme of an complementary medicine, alternative and complementary medicine. Here, first thing we need to know the importance of the palliative care. What do you mean by palliative care? Palliative care is an holistic approach which improves the health-related quality of life of the families as well as the patients as well as the other caregivers who is associated with the patients in issues associated with then chronic life illness. As we all know that cancer is a chronic illness. It's not like that it comes for 1 month, it will go for next month. It's a chronic illness. It's a lifelong process where it's only possible we can stop the elevating of the signs and symptoms, but we cannot completely suppress the disease progression. So palliative care is one of the important complementary medicine should be given to the anyone, not like just an elderly patient, but any individual who is suffering from the life-threatening illness. The palliative care is an holistic approach. As I said, holistic means it includes every sort of treatment, like it may be physiological, it may be psychological, psychosocial, emotional, as well as spiritual distress faced by the cancer patients. Now coming under what are the affective disorder challenges? Like cancer treatment itself is miserable in the cancer condition, where the treatment taken by the patient is shown by a lot of signs and symptoms, which in turn depresses their mental health, as well as it will reduces their ability to think as well as move further in their life. What is the main principle of the palliative care means? Palliative care doesn't postpone the death, it just hastens or not postpone the death. And palliative care affirms life and regards death as a normal process. So this palliative care need in this elderly patient is much more important in this era of period due to the modernization as well as due to the improvement in healthcare setup, due to the improvement in much more diagnostic tools. It has their own benefit as well as it has their own failures also. Since because of the improvement in healthcare sector, the life expectancy of the people will increase gradually. This leads to there is a more number of elderly population in India, where the Indian population is unmet and is not ready to give the proper healthcare on the demands of the patient. Next slide. My introduction. As I said, cancer is a major public health economic issue and it's a burden set to spiral. Over 18 million cases in 2018, we can expect 29 million cases by 2040 due to the aging as well as the growth of population. According to the population census of 2011, there are nearly 104 million elderly persons, which is like a greater number of 60 years and above. And we can expect 19% higher in upcoming years, that is 2050. In this point of view, we should rethink our healthcare infrastructure, whether we are ready, whether there is a number of, for the COVID condition also, you are saying that there is a lot of unmet medical surveillance we are giving for the patient. We are giving, means there is a decrease in the healthcare professionals like doctors, nurses, as well as the counselors. So if it is the projected rise up to 19% 2050, are we ready to give any sort of healthcare needs necessary for the patient? According to the Indian Ministry of the Social Justice and Empowerment, the number of 60 plus age group will increase from 14.3 crore in 2021 and 17.3 crore in 2026. So it is an alarming rise in an elderly population. Coming to the palliative care scenario in India, approximately only 1,000 palliative care units are present actively in the India. About 90% are being located in Kerala itself, which caters only 3% of the country's population. In country's population of 100%, we can only see 3% of the total population in India are taking the benefits of the palliative care. Rest 97% of the people who are suffering from the life-threatening illness will not be enrolled to the palliative care and will not be getting the benefits of the any healthcare system provided by the government of India. Palliative care policy in the government of Karnataka provides estimate about 4.48 lakhs people are dying in Karnataka with a population of 64 million and a crude mortality rate of 7.1%. The rate estimated that around 60% of the people who are dying without the benefit from the palliative care into the management plan. It is estimated that 2% of these patients receive the palliative care. This is the scenario of our own state, Karnataka. What is the main drawback of it? Untreated, inadequate. Hello?
Yes,
Is it audible?
you are audible.
Okay. Untreated and inadequately treated patient of the pain have a serious adverse effect on the physical, physiological, health, function, ability, as well as quality rated of in cancer patient. What happens means whenever the cancer patient will admit to the hospital, he should be take care not only by just treatment wise, but also its social and physiological factor. If it is having a cancer, then he will be suffering from lot of pain. There are 100% of people will be suffering from the pain. And if it is left undiagnosed or if it is left properly assessed, then this may lead to the affective disorders. He may think that he's having anxiety, he may think that he's having pain, means it will be going to prognosis his cancer condition. It may further lead to the depression condition of the patient, which is a major barrier for the treatment of the cancer. For most cancer patients, life continues to be a problem. Several obstacles have been identified to prevent patients from achieving the optimal care, as I mentioned before. And last part of the introduction is, as there is an increase in life expectancy, as I said, due to the census, from the birth expectancy from 67.5 to 70%, I mean 78 by 2025. And we are unequipped to meet the demand due to the shortage of the doctor. And one thing I need to add in here is, due to the modern nuclear family, the people in the home are reducing. The guy who is the maintaining of the home, he will be in work, and as well as the housewife, she will be also in the work. So there is no one to take care of the elderly people. So that's where the palliative care plays a very important role, and the nuclear family have a major burden in the treatment of the palliative care. My need of the study, as I mentioned, to assess the need and importance of the palliative care in distressed elderly patient, to determine the influence of palliative care in the psychological challenges faced in the management of overall health-related quality of life. Materials and methodology. We have conducted this study in the Bharat Hospital and Oncology of Mysuru, and it's a prospective observational study. All the study period was 6 months, and all the study data were collected due to the patient interview, as well as patient case records, as well as relevant necessary data are collected. And the study criteria, we are involved the patient who are suffering from cancer. Since we are doing a project on, as well as a thesis work on the cancer, we're selecting them as a study criteria. Methodology. All patients meeting the study criteria will be enrolled in the study, as well as obtaining an informed consent, and all relevant diagnosis data, as well as pre-history medication allergy status are collected. Pain is assessed in the patient with the help of a brief pain inventory questionnaire. Results were interpreted on a qualitative basis. This brief pain inventory questionnaire is a 14 questions, in which it improves the patient assessment for the pain. Is the patient is suffering pain like where he's suffering the pain, how much strong he's suffering the pain. In the assessment scale of 0 to 11, we can interpret the pain severity scores. And coming his mental status were assessed with the help of an HADS, that is Hospital Anxiety Depression Scale, where 14 questions, 7 of each represent the anxiety and 7 of each represent the depression. And all the data were collected, were statistically done with the help of an SPSS analysis software, and the outcome data were represented or interpreted in the descriptive and inferential manner. And these are the coming to the result part of our study, where we got a patient characteristics of distribution of age this, like 15 to 30. Here we consider on the elderly population, that is greater than 75, from 60 to 75. This is the patient demographic information related, that is like out of 183 patient, out of 183 study sample, 57 studies. Hello?
Great.
You can mute yourself, sir. You can please mute.
Okay, out of 183 study sample, 53 study sample were found to be in an elderly population that constitutes a 31.14%, 31.14% of the total study population, among which 67% constitute a male gender, which like it shows the gender distribution of the elderly population. Now, prevalence of the cancer type. Here, if you see the prevalence data of the cancer type from our study sample, we can see that gastrointestinal cancer as well as the head and neck cancer poses a greater risk in the patient. That is 31.6% gastrointestinal cancer and 29.9% caters the head and neck cancer. These cancers having utmost importance. Why? Because when compared to other sort of cancer, these both cancers have more complications. Like if it is gastrointestinal cancer, the person will be having a reduced weight, difficulty in swallowing, as well as nausea and vomiting. Whenever the person enters the elderly age, his main goal will be like he need to lead his life, upcoming life, in a betterment manner. The most important thing in our normal human life is food, sleep, as well as the work. If his part of work is done in his younger age, and now his part of work is only sleep as well as having food and leading a good life. If at all the patient is, that is elderly patient, one is suffering from the gastrointestinal cancer and head and neck cancer, he might be not having a proper digestion as well as he can't even swallow the food. So it definitely affect the health related quality of life of the patient. So in order to alleviate the signs and symptoms in this category of the patient, we need to promote more palliative care. Now coming to the palliative care in the stages of cancer, here we can see the majority of the patients will be admitted to the hospital at only stage 3 and stage 4. It constitutes about more than 60%. This may be due to the major of the factors, like due to the knowledge, improper knowledge about the disease, due to the awareness, lack of awareness, due to the economic instability, as well as due to the patient cyberchondria. It is one of the taboo in the Indian scenario, where cyberchondria leads to the improper diagnosis, that is self-diagnosis due to the Googling. So he may fear that he will be getting cancer if I go to diagnose. So he will be staying at home at the primary and secondary stage. So when his symptoms will get elevating, he will be attending to the hospital at very late age. At this condition, the treatment of the patient as well as the prognosis of the disease will not be happening, and the patient's treatment cost will be much more. It may lead to the cost-effective analysis. During the cost-effective analysis, it showed that there is a decreased prevalence of there is a decrease in life expectancy as well as increased cost burden on this patient. When coming to the palliative care in these stages of cancer, the common Indian scenario is palliative care should be given to the patient only if the patient is going to die or no treatment options is having an effect on the patient. But it's a wrong scenario. But this is a wrong assumption. Like whenever you take the all developed countries or developing countries, palliative care is given at the young stage. That is, at the time of a diagnosis itself, the palliative care is administered to the patient. It will help in decreasing the elevating signs and symptoms, as well as it will decrease the psychological distress in order to improve the patient's confidence regarding the treatment of an upcoming cancer treatment. If you see here, means stage 3 patient have 40.14% of a study population. In this, only 6 patients, that is constitutes of 26% of the patient are receiving palliative care. Rest of all patients, that is 74% or is not taking a palliative care. It is a much more burden to the patient, is more economically as well as psychologically. So when you take all the palliative care in this stage from 1 to 1-4, we can only see only 21.05% out of 100% what the health education, what the health scenario of Indian is expecting. Only 21%, which is a very least number of the patients are taking benefit of the palliative care. Coming to the BPA, pain severity and pain interference, we can see that 30 patients, that is a half of the study sample, are in the severe condition. That is, that half of the patients are suffering from the signs and symptoms of an pain and agony in suffering from the cancer. Next comes under moderate pain, and that is 24%, 24, that is 42.1%. Here we can note the two important factors, that is the blue one as well as yellow one. The blue one says that the high interference, whether the pain suffering from the patient is interfering in his day-to-day activities or not, whether the pain he is having is disturbing his daily activities or not, like just like a sleep, mood, walking ability, as well as his relationship between the society. We have saw many patients after getting a cancer, they idolize themselves, they should not talk to the people, they should not let to the grandchildren to them, just because they think that I have cancer and I may die soon and I should not spread the cancer. This kind of ideology in their mind will lead to this kind of problems. Like the patient who's having a severe kind of pain, he will be thinking the knowledge that, okay, I will be having pain, then I will be suffering, I will be going to die more faster. So this kind of negative assumptions creates the patient and puts into mental distress. Okay, coming to the next step is the hospital anxiety and depression scale. This analysis helps us to prove that how many of the patients are at the verge of getting anxiety as well as depression, how many already got the anxiety and depression. Here we can see only minimal number, that is 8 to 9 people, 8% of the people are getting 8% of the people are getting depression, and 14% of people are getting depression, and 15.8% are getting normal. When compared to much more abnormality, we can see 49.1% patient who is having pain will be getting a depression, as well as 36.9% are verging to get depressed. So it is one of the important thing we need to focus on is the group of the patient who are in the borderline. Like the person who are already entered into the abnormal condition of the depression, we can give the cognitive behavioral therapy, or also we can give the mood elevating therapy. We can give some of the medications which may finally improve his status of the health, but it may have a cost effective burden on the patient. But we need to concentrate more on the borderline people, like 40.4% people are in the borderline of an anxiety, as well as 25, that is 43.9% are the verge of getting anxiety. This area of the group of patients we need to concentrate more. Why? Because there is no proper concentration on these kind of people, means there is no proper treatment for this kind of people, means they may develop the upcoming affective disorder, which is much more devastating than the treatment of the cancer itself. The inferential statistic of analysis of this test says that pain severity showed a positive moderate correlation, that is used by a Spearman correlation. Since our study data is an non-normal distribution, we took the non-parametric data analysis, that is Spearman correlation. It shows that it has a positive moderate correlation, which is a statistically significant value. We can see the p-value is very less than 0.01. As anxiety also showed the positive correlation with an daily life, that is interference. What it says means pain severity, as the pain severity increases, the interference in the daily life is also increases. If he is having pain, he won't be having much mood to talk to people, he won't be having any sort of sleep, he won't be having any sort of food, he won't be living his life joyfully. And anxiety also, as there is an increase in the pain, he feels that, okay, I'm having more pain, I will be more anxious now, I may going to die more sooner. So it will not improve his health status, but it will decrease his health life expectancy, and it may create the fear of death in his upcoming years. So conclusion of my study is the proper assessment of the cancer pain and enrolling patients in the palliative care can help to improve the health-related quality of life, along reducing the chances of developing affective disorders. Here it's important to note that assessment of a pain isn't subjective. We can't say that the patient as well as the physician, what they're taking, is he have to completely depend upon on the patient. If at all the patient is happy in mood, he can say correct data. If at all the patient in distressed mood, if at all the doctor physician is not so friendly, the patient will get fear of saying their agony as well as fear of saying their pain to the hospital management or the physician. It may create a bias in the data collection. So the proper assessment of the cancer pain is first of one thing which we need to concentrate more. If at all the patient is having much more pain, then the brief pain inventory has shown a better efficacy pain assessment tool. Why? Because it not only grades the pain, but also it helps in interpretation whether it is having any interference in the normal day-to-day life or not. This brief pain inventory shows an efficacious pain assessment tools. Like a financial burden as well as the low-income mortality and minority group should be given more concentration because it may lead to the poor prognosis of the health quality of life. The continuous screening of an anxiety and depression is recommended as a crucial approach for the good cancer management. Hence, identifying the critical barriers in the effective management of cancer pain and the implementation of this palliative care in a curriculum of the government issues, like majority of the government schemes, if we include the palliative care as a major complementary and alternative medicine, it will gradually increase the life expectancy of the distressed elderly cancer suffering patients. At final, it will increase the health-related quality of life. Thus, I conclude my topic: how the palliative care need is necessary in the affecting disorders of the cancer patients, especially in the elderly population. These are the references. And finally, I conclude by saying thank you to care for those who once cared for us in one of the highest honors. Thank you.
Thank you, Mr. Sachidananda, for sharing your reflective knowledge with us. Without further ado, I would like to invite and introduce our next speaker, Dr. Shanmugarajan Krishnan. Dr. Shanmugarajan Krishnan is currently working as a research fellow in Edwin L. Steele Laboratories, Department of Radiation Oncology, Massachusetts General Hospital and Harvard Medical School, Boston, USA. He completed his PhD degree in neuroscience, University of Zurich, Switzerland in June 2016. He obtained master's in biomedicine from Karolinska Institute, Sweden in June 2012. He has 10 to 15 publications. He has been awarded with funding from US Department of Defense, peer-reviewed Center Research Program, Ellison Foundation and National Foundation for Cancer Research, Swiss National Science Foundation Early Post-Doc Mobility Fellowship. He is a member of American Society of Clinical Oncology. He is a reviewer for journals like Friends in Pharmacological Sciences, Frontiers in Oncology, Biochemy, Science Matters. Thank you, sir, for being with us today. Now I request you to deliver the talk. Over to you, sir.
Hi, ma'am. Are you able to hear me?
Sir.
Yes, sir.
Great. Great, sir. Let me share my screen with you. Can you now see my screen?
Yes, sir. This is.
Great, great. Hi, everyone. It's been my fascination to work on neuroscience and oncology for the last 15 years. I've chosen this field because of its intricacies and because of its complications and because of its challenges. Let me jump into the topic directly, targeting the adult brain tumor microenvironment to improve current therapies. So this is a picture from a cerebral cortex showing the vasculature consisting of the blood vessels. So I'm going to talk to you about a specific adult brain tumor called glioblastoma. The World Health Organization classifies glioblastoma as a grade 4 malignant brain tumor. Patients report with the symptoms of nausea, headache, visual impairment, seizures, cognitive and muscular disorders. So once a needle sort of biopsy is done, the doctor confirms the pathological status, and if it is confirmed to be glioblastoma, then the doctor sees if the tumor can be resected or removed. So for this purpose, they inject a fluorescence dye, which is called 5-alanine, to enhance this tumor region. So we see that using a neuro, and the panel B, we see that using a neuro navigation procedure, the right ventricle of the brain has been opened up and the tumor is being removed. In panel C, you can visualize that after the tumor is being completely removed, this contrast enhancement area is taken off as much as possible without interfering with the normal function of the brain. right? So this is one standard of care. The next standard of care simultaneously is chemo and radiation. In publication, which is a path-breaking publication in 2005, you can see that from this graph, the probability of overall survival is given on the y-axis. Radiotherapy is in the orange arm, and radiotherapy plus chemotherapy, which is called temozolomide, is in the blue arm. You can see that the median overall survival is increased by approximately 2.5 months. This was the maximum that was possible 15 years ago. But 3 years ago, there was another standard of care called tumor treating fields, which again improved the survival of the chemo and radiation by 2.5 more months. So this is what we are having as treatment options at the moment. The interesting feature of glioblastoma is that if you see in this graph, the incidence rate per 100,000 persons, female, male, and combined, and the age at diagnosis is given in the x-axis. So you can see that it peaks about 70 years, as you see from here. And importantly, the more age you are in, then and if you have glioblastoma, you will be living for a shorter lifespan. And if you see here in this red box, if you're above 60, then your median, that is 5-year probability rate, is less than 5%. So this is important. This is the challenging part of the tumor. And although the doctors can remove the tumor after surgical resection, the tumor 90% of the time recurs, and that is called recurrent glioblastoma. And because of this, and if you have recurrent glioblastoma, and if you are older, then your functional status is poor, and therefore the only option would be hospice and supportive care. So with this, what question we had in mind is that this tumor is full of vascular. So the rationale for our study is that this abnormal vessels in the tumor. Because of these abnormal vessels, there is high interstitial fluid pressure, there is irregular blood flow, and then there is low pH. Lack of oxygen, uniform oxygen is lacking. Therefore, you cannot deliver drugs into the tumor. Other than that, the brain actually is covered by an envelope of endothelial cells, which is called the blood-brain barrier. Most of the drugs do not penetrate this barrier. And the important feature here is this tumor microenvironment. That is, this irregularity in the blood vessels causes hypoxia and hinders with any treatment possible. So what did we do? We identified a molecule called vascular endothelial growth factor, and which we blocked using an anti-VEGF therapy. So VEGF is the molecule, and we use anti-VEGF therapy to make these abnormal vessels normalized. And if you see in a patient where the tumor is on day -5 and -1 before the treatment of anti-VEGF therapy, immediately starting anti-VEGF therapy, that is 1 day after starting, you see that the tumor enhancement area is reduced. This goes on to be reduced until day 111. You can also appreciate that the vascular permeability in the lower panel before treatment is really high, whereas after treatment, immediately after treatment, the vascular permeability reduces, and it keeps on reducing. This was an innovative part of this treatment. However, the problem is that in phase 3 randomized clinical trials, bevacizumab, that is anti-VEGF therapy, if you see the panel C here, the overall survival is given on the y-axis, and the study months is given on the x-axis. Compared to radiation and temozolomide in the green curve, the anti-VEGF therapy, the blue curve, did not improve the overall survival. Any drug should improve overall survival to get approved by the FDA. At the same time, but what is the advantage of this drug is that it improved the progression-free survival. What is that? You have a disease, but the disease is just not progressing, it is just stable. It is improving the progression-free survival by about a couple of months. So, however, the problem with anti-VEGF therapy is that this following. So we had patient issues before treatment with anti-VEGF treatment, and the same patient tissue after anti-VEGF treatment. What you see here is pre-anti-VEGF and post-anti-VEGF. Post-anti-VEGF, you see the increase in the Wnt7 protein pathway. What is this pathway? This is actually bad for the patients. If this pathway is increased or upregulated, there is an enormous amount of stem cell maintenance. A stem cell is even if one cell of a cancer cell is stem cell, it can reproduce the entire tumor. And then the Wnt pathway is involved in invasiveness and also resistance to therapies like radiation and chemotherapy. Right. So our work was inspired from particular work, which is about oligodendrocytes. These are neuronal cells which can actually, the function is to myelinate the axons. It acts like a shock absorber for the axons, And then what we saw in the developing mouse brain, that is these people, Sai et al. Published in Science, they saw in the developing brain that oligodendrocytes can travel along the vasculature. So if you see the embryonic 18th day cortex of a mouse brain, at 0 minutes, this is a cancer cell. I'm sorry, this is an oligodendrocyte. And then this one, in 51 minutes, if you see, it is attracted towards the vessel, and in 68 minutes, it travels along the vessel, and in 102 minutes, it goes even further. And you can also see that Wnt7b and Wnt7a are co-stained with OLIG2, which is a marker for these oligodendrocytes. This was the inspiration for our work. So in our research team, we've got our own animal colony, and we have transgenic mice, genetically engineered mice, and all that. And so we use a technique called cranial window imaging using multiphoton microscopy. So what we do is to remove the surface of the skull of mice so that we can visualize the vessels, right? In the future images, any vessel would be in red color because we have injected a tracer molecule called dextran, which is conjugated to rhodamine, and then the blood vessels can appear red. We do it by retroorbital injection. Now the cancer cells are transduced with the green fluorescent protein, which can be visualized as green color. So this we visualize under the microscope using a cover slip. So we open the skull, then implant the cancer cells, and we are able to visualize the dynamics of these cells. What we found here is that the glioblastoma cells are attracted towards the vasculature, towards the blood vessels. You see, blood vessels are red, cancer cells are green. And if you see this area in day 2 after implantation, there is not much of, not many cells are near the vasculature. But on day 5, most of the cells are attracted towards the vasculature, and on day 8, they grow along the vasculature. This region is magnified here, as you see here. The more yellow, that means the green and red are combining together, and they are growing along it. So this was fascinating. However, what we interestingly saw was that there were 2 modes of invasion of these cancer cells. These are directly, the D54 is also a patient-derived cell line, and MGG8 is again a patient-derived cell line. What we see here at the D54 model is that they invade in a collective manner. There is a group of cells invade along the blood vessels, but mostly they're not in contact with the blood vessels. But at the same time, if you see the MGG8, what we see is that there is single cell invasion. So collective versus single cell invasion. And interestingly, we classified them as OLIG2 positive and OLIG2 negative cells. We transcriptomically profiled these tumors. And what we surprisingly saw that the OLIG2 positive cells had an upregulation of the Wnt pathway again, and a downregulation of the VEGF receptor pathway in the OLIG2 positive cells. So let me just show you some fascinating images about the MGG8 cells at a single cell resolution. This is one cancer cell which is hugging the vessel. And this is another one. And if you see this one, it is extending its protrusions called philopodia on the blood vessels and walking across it. And this cancer cell is actually trying to connect one blood vessel to the other and invade. So this is really bad for the patient. So what we see here is again at a single cell resolution that you can observe this blue dotted line here. And this single cell in 0 minutes, in 10 minutes, 20, 30, and 40 minutes, if you see, 30 and 40 minutes, the protrusions are really extending and it's moving away from this blue line. This was a significant achievement because before this, nobody was able to look at it at this perspective. As I would like to recap a little bit, because I told you that post anti-VEGF treatment, there is increase in the Wnt7 protein. Similarly, when we profiled OLIG2 positive GBMs, which is with glioblastomas, we saw an increase in the Wnt7 pathway. So Wnt7 pathway is bad, as I mentioned. So our strategy was to target this pathway, right? What are the different strategies? So there are 19 Wnt molecules, right? So it's complicated. So where to target this, at which level? What we did was to target an enzyme called porcupine, and LGK974 is a drug from Novartis. And we used this drug to block this enzyme function so that Wnt7 molecules cannot be secreted in the environment. Once they are secreted, what happens if they are secreted is they bind to a receptor called frizzled, and then there is downstream pathway activation, and the beta-catenin gene actually translocates to the nucleus of the cell, and then using co-activators, they transcribe different genes. So there are drugs blocking beta-catenin, blocking the assembly of beta-catenin, or blocking the co-activators, which are downstream. So what drug we used is LGK974, which just blocks the secretion of all Wnt molecules. And these Wnt inhibitors are in clinical trials for other extra central nervous system tumors, which is head and neck cancer, colorectal cancer, but only in phase 1 and 2, not been approved by FDA. So what we thought, we can repurpose this drug for the GBM patients, which is glioblastoma patients. I think my audiences would be interested in this slide very much because of its. They're showing here the pharmacokinetics and of which is basically the blood, and then you have the increase in the brain as well. So this red bar has been shown in this graph here. That is, after administration of LGK systemically, it is increasing in the brain at 12 hours. So this is very important. As I told you, there is an envelope called the blood-brain barrier, and this does not allow most of the drugs to enter into the brain. But LGK does that. It can penetrate the brain and also do its function, which is blocking the Wnt pathway, Wnt7. The mice treated with LGK974 did not lose their weight at all. And similarly, there was no toxicity associated in other peripheral organs. So what did this Wnt inhibitor do? Was it able to block the perivascular invasion? Yes, it was, to an extent. As in the sense, the vehicle tumors where the cancer cells were traveling on the vessels, you remember? This contact of cancer cells to the vessels has been abrogated with using LGK974, as you can see from the decrease here. Is this clinically relevant? This is what we asked. So we implanted mice with glioblastomas, and then we started treating them with LGK974. And I want to recap once more. In my initial slide, I showed you about radiotherapy plus temozolomide, which is a chemotherapy, which enhanced the benefit for about 2.5 months, right? So we wanted to test if LGK974 can increase the efficacy of the chemotherapy called temozolomide. So here we did this experiment. And what we see here is that the vehicle-treated mice, that is, the percentage of survival is given here, and this is days after implantation. The control mice die at about day 42. And then the LGK-treated mice, that is the monotherapy LGK-treated mice, show no difference. They are not improving the survival at all. Whereas temozolomide chemotherapy improves the survival drastically, about 20 days. And temozolomide in combination with LGK974 can further extend this survival. Well, an important point to note in this tumor is that we started treating these tumors at about 10 millimeter cubed, which is really a huge size. And this survival significance, it does mean a lot, but is it enough for curing a patient? Then I would say no. because this survival for curing has to be like straight like this. Mice should survive for a longer time. So the significant achievement of this work, as I mentioned to you, is to look at cancer cells. It's a single cell resolution on blood vessels. So that was published in 2018 it was a huge collaborative work from Harvard Medical School and the University of California, San Francisco, and I was a key part of it. And but as I told you, this is not enough. So that is when immunotherapy started booming. So what I would like to explain to you is that a cancer cell has to present a small molecules or peptides called antigens to the immune system. It has to be visible to the immune system, and this process is done by cells called antigen presenting cells, which actually the second step is given here, and they can travel to the lymph nodes to present the antigen. And once the antigen is recognized in the lymph nodes, the T cells have to travel back via the blood vessels, and they penetrate the tumor region, and they recognize the same antigen at the tumor, and then they kill the tumor. So these T cells, just remember the word cytotoxic T cells, and they are the ones that are killing the tumor. So, but the tumor is really, really smart. What it can do is to hide itself from the immune system, as I mentioned, and then it can down-regulate its antigen presentation machinery, and it can make the T cells inactive and prevent them from killing the tumor. So there were these two molecules which were discovered in 2018. Discovered long back, but the Nobel Prize was given in 2018. So what I'm trying to tell you here is that these two molecules are called programmed cell death protein and cytotoxic T lymphocyte associated antigen. What you see here is that the antigen presenting cell actually is this one. So it gets the antigen from the tumor cells and it presents it to the T cell. As you see here, this is the blue color is the antigen. However, they also express a molecule called CTLA, a ligand for CTLA4, and the T cells express this CTLA4 receptor. When this interaction of the ligand of CTLA4 and CTLA4 happens, the T cells get inactivated. As you see, the signal is inhibited. Similarly, the case for PD-1 and its ligand. When this interaction happens, the T cells get inactivated and exhausted. So as I mentioned, for this discovery of the negative immune regulation, Dr. James Allison and Tasuku Honjo were awarded the Nobel Prize in 2018. This therapy is called immune checkpoint blockade. That is giving an antibody to block this interaction of negative modulators called plus cancers. As you can see here, you can see head and neck cancer, malignant melanoma, ovarian cancer, cervical cancer, and non-small cell lung cancer. These are all the cancers which are responding to this checkpoint blockade, right? However, you wouldn't see which tumor, you wouldn't see glioblastoma here. So the reason is that in a phase 3 clinical trial, if you see, this is nivolumab, that is the antibody. I also forgot to mention to you about another antibody called pembrolizumab, which is a company called Merck is manufacturing it. And it has a common name called Keytruda. So this nivolumab is manufactured by Bristol Myers Squibb. So you see that in this probability of overall survival, bevacizumab, which is the anti-VEGF therapy, which I mentioned earlier, is on a light blue bar. And nivolumab, which is the anti-PD-1, that is immune checkpoint blocker, is on the dark blue bar. So you see there is no difference in the overall survival in glioblastoma patients. So we have another failed phase 3 clinical trial. The reason is several. First of all, that checkpoint inhibitors have revolutionized cancer therapy. That's true. As you see here, the patients, cancer patients eligible for checkpoint inhibitors increased from 1.54% in 2011 to 43.63% in 2018. Whereas the patients who respond to checkpoint inhibitors only increased from 0.14% to 12.46%. So a remaining vast majority of 80% of these patients do not respond. So the reason is the following. The patients who respond, if you take those tumors and look at them, this is a CD8 T cell and interferon gamma signature. If there is pre-existing immunity, that is, if the T cells, I mentioned the cytotoxic T cells, if they are there in the tumor already, then these patients respond better. However, there are also other scenarios where there are no tumor cells at all, which is called immune desert. So these patients do not respond. Similarly, if the immune cells are sequestered in one periphery of the tumor, they also don't respond. Again, there could be T cells in the tumor, but they may not be functional. As you know, with anti-PD1 and anti-CTLA4, that is what we are trying to improve. So glioblastoma actually lies between these three classifications. So if it is between these three, then the response gets lower. And further, there are several side effects of immune checkpoint blockers, like gastrointestinal, dermatologic, endocrine, and pulmonary side effects. And most importantly, the glioblastoma tumor microenvironment is suppressive. So as I mentioned about the abnormal blood vessels, right? They secrete immunosuppressive factors such as VEGF, TGF-beta, and prostaglandins. And they increase the infiltration of bone marrow-derived suppressor cells and regulatory T cells. The function of these two compartments is to suppress the antigen-presenting cells and affect the cytotoxic T cells. So what is supposed to increase is actually decreasing, and what is supposed to decrease is actually increasing. So the suppressive compartment is increasing. What our ongoing work is focusing on is that we are targeting every compartment, myeloid-derived suppressor cells. For example, we have macrophages. We are using a CSF1 receptor inhibitor in combination with radiation, and we and others have seen improvement of survival in preclinical models. We are targeting the T regulatory cells also using compounds, and we are increasing the antigen presentation machinery and the infiltration. That is most important. Infiltration of T effector cells into the tumor and kill the tumor. This is what is ongoing work. The other interesting aspect of this research is that there's a therapy called chimeric antigen receptor therapy, T cell therapy. So as I mentioned about these cytotoxic T cells, you have what is done here in this is that patient's blood is taken, and then the T cells are isolated, and they are artificially, that is, engineered to express a certain receptors which are targeting the tumor antigens, and then they are modified and given back to the patient himself. So this actually increases the probability of the tumor cell killing. And the interesting aspect is that they are given locally, even in preclinical models, they are given at a local environment to bypass the blood-brain barrier, so that they're not blocked. But before I tell you about the limitations of this therapy, I just wanted to show you how a CAR T cell looks. That's a T cell. That's a T cell, yeah. And then you have this CD3 zeta domain, which is a signaling domain of the T cell. You can actually make the T cell express this entire molecule with the CD8 domain, and you have this IgG-like domain at the forefront. And you see the antibodies, variable, heavy chain, and light chain are here. So this can directly recognize the tumor antigen. Whereas in the normal scenario, you need a antigen presentation machinery called MHC1 or MHC2 to present this antigen. Whereas in the CAR T approach, you can directly target tumor antigens. This is an advantage. However, there are limitations, which is these T cells, when they enter the tumor, they are not proliferating enough. There is also exhaustion in these tumors, in these T cells. So there is resistance because of the immunosuppressive tumor microenvironment again. Although they are working well, that is, they are showing benefit in hematological malignancies, the benefit in solid tumors has been minimal, but there's been ongoing research on improving these therapies by adding a co-stimulatory domain, by modulating the CAR T cell receptor, and then by giving locally. So all these processes are going on. So, so even if you did not listen to all what I said so far, it's okay if you just look at the last two slides. So the take-home message is that invasion in glioblastoma is the main reason for its recurrence. Because of this invasion, they are not detectable by MRI, and the tumor Even if there is one stem cell, the entire tumor recurs. So as you can see here, I showed you two modes of invasion. One is a collective mode of invasion, and the other is a single cell fashion invasion in the OLIG2 positive and Win7 positive models. The second slide about take-home message is that LGK, as I told you, it can penetrate the blood-brain barrier, decrease the invasion, and improve the survival benefit of chemotherapy to a level. But what we need is a cure. So we have to combine drugs with immunotherapy and immunotherapeutic approach to get long-term survivors and get a cure. This is the best mode of approach so far discovered. So what you see is, you remember the immune checkpoint blockade therapy, where we have the PD1 and CTLA4, and you have the antibodies against them to restore the anti-tumor immunity. And finally, the CAR T cell therapy, which is a promising approach, and it's being exploited for the benefit of the patient. And finally, I would like to acknowledge my mentors for this presentation. Professor Rakesh Jain from the Department of Radiation Oncology, Harvard Medical School and Mass General Hospital. Professor Michael Weller from the Department of Neurology, University Hospital Zurich, where I did my PhD in Switzerland. And Professor Venkataratna Kumar Tyagarajan from the Department of Pharmacognosy, College of Pharmacy in Madurai Medical College. Without them, it wouldn't have been possible for me to make this presentation here. And I thank the organizers, most importantly, Dr. Muthuraman and Dr. Joshi. So I thank them very much for giving me this opportunity. So I hope they also invite me next year to give you an update on the current ongoing work. So I thank you for your patience and attention. If you have any questions, please email me at skrishnan5@mgh.harvard.edu. I appreciate your patience. Thank you very much.
Thank you, sir, for giving valuable insights on the topic, targeting the brain tumor microenvironment to improve current therapies.
Thank you.
So next, thank you so much, sir. Next, we can move on to our last speaker for today's session. I take this privilege to introduce our last speaker for today's session, Professor Mangestuti Agil. Professor Dr. Mangestuti Agil is currently working as a professor in the Department of Pharmacognosy and Phytochemistry, Faculty of Pharmacy, University of Erlangga, Indonesia. She completed her Bachelor of Science in Department of Pharmaceutical Technology from University of Erlangga, Indonesia. In 1987, she obtained MPhil in Basic Medical Science from University of Erlangga, Indonesia. In 2000, she has been awarded with PhD degree in Mathematics and Natural Science from University of Erlangga, Indonesia. Her areas of interest are alternative and complementary therapies for women's health, aromatherapy, Indonesian and other Asian traditional medicines, medicinal plants with anti-osteoporosis property, medicinal plants with neuroprotection property, and medicinal plants for skincare. In 2019, she was invited as speaker to talk on the topic, Unlock the Honor of Nature's Medicine of Jammu at Innovative City Forum. He has also visited several parts of India to study the role of herbal medicines for women's health of Indian and Indonesian traditional medicines. Now I request Dr. Mangestuti Agil to deliver the talk. Over to you, ma'am.
Thank you very much. Thank you very much. So I will share my slides. So, how about full screen? For the full screen, what I should do?
Madam, can you click on the PowerPoint, your presentation? Yes. Yes.
Already?
Yeah, you can click on the slideshow. Yeah, that one. Yes, yes.
Yes. So you can already see.
Carry on, madam. We can see. We can see it.
Okay, thank you very much. Good afternoon to all speakers and participants of the conference. I would like to thank especially to Dr. Josie for giving me such great opportunity to be one of the speakers in this conference. I am a pharmacist and work for the Faculty of Pharmacy, University of Erlangga in Surabaya. And the department deals with medicinal plants and traditional medicines. Since the year 2000, I sought to focus my work on women's health, especially related to the application of natural ingredients. Therefore, to me, this conference is one of the right place where we can discuss more deeply about healthy aging. This is especially important in Indonesia, where women in the community where I'm living have not been paying much attention in preparing a good quality of life throughout their life stage. So here I'm going to share with you about phytoestrogens for healthy bones and brain in postmenopausal women. As we all know, menopause is a stage where women experience reduction in steroid hormone, particularly estrogens. So many other changes resulted from altered steroid hormone levels during the postmenopausal period, and this is caused the quality of life change, which include hot flushes, sleep disorders, fatigue, mood change, and urinary and sexual dysfunction. Reduction of endogenous estrogen level will increase risk of, among others, bone fractures, cardiovascular disease, and Alzheimer's diseases. Postmenopausal women have a higher risk of developing osteoporosis. Prevalence of osteoporosis in females increases significantly in postmenopausal population after ovarian function is lost, and continues to increase with age throughout the postmenopausal period. WHO reported that people aged 60 years of age and older make up over 11% of the global population. And by 2050, the number is projected to rise about 22%. Osteoporosis is the cause of approximately 1.5 million fractures every year, and the most common are hips, spine, and wrist fractures. People always think that estrogens are simply female sex hormones for gonadal organ development and function, but actually estrogen have critical function in other tissue, including liver, heart, muscle, bone, and brain. Now I'm talking about receptors. Estrogen acts through two types of their receptors. Classical nuclear receptors. There are two, alpha estrogen receptors and beta estrogen receptor. Novel cell surface membrane receptors. While recent studies reveal that brain estrogens protect against insults-induced neuronal damage via both nuclear and cell surface membrane receptor. Now, how about estrogen and the brain? Research found out that estrogen plays a pivotal role in the regulation of important brain function, which include cognitive function, neural viability, and against neurodegenerative decline. Deprivation as a result of menopause will enhance degenerative change. In 2015, for example, 46.8 million people suffered from neurodegenerative worldwide, and the number will increase and reach 131.5 million by 2050, where majority is women. This is because women's life prevalence is 70 to 80 years of age, while menopause is relatively stable at 50 to 51 years of age. So it means that women spend 1/3 of their life in postmenopausal stage. So about the physiological of estrogen, there are three major forms of physiological estrogen in female: estrone, estradiol and estriol. Estradiol is a major product from the whole biosynthesis of the process. This is the most potent estrogen during the premenopausal period in a woman's life. So now people are start talking about estrogen replacement or hormone replacement therapies as alternative. Actually, there is a growing body of information about the estrogen replacement or hormone replacement therapy. A broad foundation of research support the use of ERT and HRT for improving various factors that are believed to influence quality of life in menopausal women. So, estrogen therapy plays osteoporotic roles in both osteoporotic humans and rodents, but it still remains controversial against heart disease or Alzheimer's disease. But preliminary investigation revealed that estrogen-containing therapy could reduce Alzheimer's disease, Alzheimer's risk, attenuate disease-associated cognitive deficits, and modulate brain substrates known to be dysregulated by the condition. Hormone replacement therapy itself doesn't appear to reap the expected benefits. When prescribed for a long duration, it is associated with many side effects. Some are life-threatening. So now people start talking about phytoestrogen as an alternative to synthetic estrogen. So what is phytoestrogen? It is an estrogen-like compounds derived from plants. Structurally, it is similar to estradiol. So it is able to bind with alpha and beta receptors of estrogen. Source of phytoestrogens are nuts, for example, seeds, fruits, and vegetables. But we have very important source of phytoestrogens from soybean. It's isoflavones, very famous, very popular. So how about phytoestrogen and bone health? Yeah, still not consistent, but other studies also state that there are bone-sharing benefits from the consumption of phytoestrogens, such as the administration of isoflavone-rich soy milk for 2 years can increase 2.4% of bone mineral density in older women. How about cognitive function? Interaction of phytoestrogen with estrogen receptors is also a positive influence on cognitive function. Phytoestrogen, as neuroprotectors and antioxidants, can reduce the risk of Alzheimer's diseases. So, today I'm going to share with you about a popular vegetables which grow very abundantly in the place where I'm living now. It's in East Java province, Surabaya city, Indonesia. The scientific name is Marsilia crenata, locally named as semangi. It is so popular among people of the province so that they name it Semangi Surabaya. Surabaya is the name of the town. My research project is concerned the phytoestrogen contents of the plant. It's an aquatic plant and has been used as vegetables prepared as local salad cuisine, namely as pecel semangi. So steamed semangi leaves served with a special local dressing. It was in 2007 that the previous governor of East Java province asked researchers to find out the scientific explanation behind the application of semangi as anti-osteoporosis. To us, this is very surprising as we all don't know about that. So that is the start of our research. So I started my research in 2007, start with rice field in east part of the city, where semangi grows abundantly. Preliminary tests revealed that there are high heavy metal contents, and this is due to the phytoremediation property of the plant. But other research found that Samangi has a high mineral contents: calcium, phosphor, potassium, sodium, iron, copper, zinc, and high vitamin C. So it's an antioxidant. But unfortunately, nowadays, there is a reduced number of rice fields in the area I mentioned just now. Then that is due to the vast development of housing. This means that there is a reduced number of plant source. So what do the sellers do? They harvest the leaves during the rainy seasons, keep in a dried form, and steam the leaves before selling. So you can imagine how many chemical content left in the dried and steamed form of the leaves. But this is about the popularity of the vegetable. To me, it is easier to persuade people to eat or to take these vegetables on a regular basis. For what? For healthy life in their old age. So this is the rice field, the condition of the rice field where Samangi is cultivated. This area was surrounded by some industries, so murky waters from the surrounding areas I found. This is the salads, Samangi salad sellers. They carry everything in a bamboo basket and carry at their backs. In the picture, you can see special crackers, special salad dressing prepared from sweet potatoes, special shrimp paste, and also mixed with other vegetables. You can see in this picture, some of the sellers, most of them or all of them are women. They start leaving their village very early in the morning and go to the town to sell the salad. This is the picture of the dry leaf that they steam it before start selling. So my research is on the phytoremediation property. I tried to find out the best cultivation methods which I think could help them to help against heavy metal pollution. So also I did research on the heavy metal analysis, and also studied the chemical content of the extracts and fractions of the leaves through metabolite profiling. In silico study to study the bind affinity of the chemical content to receptors of estrogens, and of course osteoporosis and neuroprotection activities with laboratory animals and cell lines. From the study on water and soil cultivation, I found morphological differences. Of course, length and diameter of leaf stalks are different between water and soil cultivation, diameter of the stolons, density of roots, distance between nodes, and what is more is about spots of the chemical contents. Through phytochemical screening, we found out that all the spots are the same, but the soil cultivated leaves show more intensive colors of spots. So here, as you can see, differences between roots of the leaves of the plants cultivated in concrete pots and cultivated in the rice field. So much difference. So this is an indication of the adaptation of the plant to the changing of environment and to overcome the stress condition. So through this research, actually, I still recommend cultivation in the water, but with good quality of water to avoid heavy metal pollution. Excuse me. Okay, so I did also heavy metal analysis in 3 different areas in East Java province to determine and compare the lead, cadmium, and mercury mineral contents of soils and leaves. From all of the areas that we examined, there is no exit limit of lead and mercury mineral concentration. But 2 areas, there are exit limits of cadmium soil contents. It is in the soil, but not in the leaves. But one area showed cadmium content which exceed the limits. So in this research, we just recommend one area that is safe to be the place, the safe place for cultivation of samangi plants. This is where we conduct research on the cultivation. So how about anti-osteoporotic? We studied in female mice, and it showed activities, good activities. We also did phytochemical screening, extraction, and fractionation, and we found some terpenoid or isoflavonoid compounds, which we predict that is a phytoestrogen compound. We also did the anti-osteoporotic activity of some certain fraction, including normal hexane fraction in the trabecular vertebrae bone density of female mice. In these experiments, we used dexamethasone to facilitate the induction of osteoporosis, and we find good results. There is an increase of trabecular vertebrae bone thickness. Another research using osteoblast cell differentiation to evaluate phytoestrogen stimulating activity of the leaves on alkaline phosphatase as a marker in osteoblast differentiation. This also showed a good result, ability to increase the alkaline phosphatase activity. How about the anti-neuroinflammation activity of extracts and fraction of the plants? We conducted the research with human microglial cells in vitro, and for this we test internal extracts of the leaves and fractions with different solvents, including normal hexane fraction, ethyl acetate fraction, normal butanol fraction, and water fraction. So what is the result? Ethyl acetate fraction showed the best anti-neuroinflammation activity in vitro in microglia cells in vitro. And we also found out that camphorol was predicted as phytoestrogen compound using in silico test, which has anti-neuroinflammation activity in this ethyl acetate fraction. We also found 8 other compounds through in silico study, which as phytoestrogens in the extract and fractions in all of the extract and fractions, that is based on the similarity of binding affinity, pharmacophore distance, and amino acid bonds with estradiol. So, conclusion is that phytoestrogens is predicted to work synergistically to exert anti-neuroinflammation in vitro. Another study that we have been conducted is to determine, also, as we found the effect of ethyl acetate, so we proceed to the determination of the effect of ethyl acetate fraction of the leaves in decreasing free estrogen receptor expression of the free estrogen receptor, and increase of the osteocalcin expression in fetal osteoblastic cell line. So good result. So ethyl acetate fraction could reduce free expression of the beta receptor, and it increased osteocalcin expression. So from this study, we indicated that the phytoestrogen content of the ethyl acetate fraction could or was able to increase bone formation. So from the study that we have been conducted, I gave a recommendation for the application of Samangi for the maintenance of healthy aging, which is supported by its popularity, which is supported by its bioactive phytoestrogen content, and supported by scientific research as anti-osteoporosis and anti-neuroinflammation. So that is all from me, and thank you very much for this opportunity. Thank you again.
Thank you, Dr. Agil, for this valuable information on topic phytoestrogens for healthy bones and brain in postmenopausal women. That was a very enlightening talk. So thank you so much once again. So with this, we can conclude today's scientific session. We'll meet tomorrow at 10:30 a.m., sharply at 10:30 a.m. for the next oral presentations and plenary talk by eminent speakers. Thank you, one and all. Thank you.